for joining this second webinar in our Next Gen Health Technologies webinar series. Last week, we went through a presentation by Steve Wanye from Intellisoft, and he talked to us about the whole idea around open health standards and etc. And this week, we have a team from the WHO, and they're going to talk to us about the WHO SMART guidelines upon which the Open Health Stack is based on in a partnership with Google. So I'd like to welcome Garrett from WHO to take over from here. We have about 45 or so minutes, and then we take some question and answers and close at the top of the hour. Welcome, Garrett.
Thank you so much, Moses. It's a pleasure to be here, and thank you for the opportunity for us to present on SMART guidelines as an open content standard that we hope that those on the call will be able to make use of and bring to life in digital systems in Kenya and elsewhere as well. Maybe I'll introduce myself. My name is Dr. Garrett Mell. I head up a unit on public digital health technology in the Digital Health and Innovations Department here in Geneva, Switzerland. And we focus on developing guidance and open content for digital health that's consistent with what WHO recommends to countries. And I'll hand over to my colleagues to introduce themselves, Ritika and then Chris.
Thank you, Garrett. Hi, hello everyone. I'm Ritika. I work with Garrett and Chris and team on the SMART Guidelines Initiative, which you will soon hear of. And thank you. Over to you, Chris.
Thank you. Yes, and hi everybody. My name's Dr. Chris Haskew. I work in the same team with Garrett and Ritika and WHO in Geneva. I lead a project called MCare, which applies SMART guidelines in emergency settings. And I'll be introducing that a little later. Back to you, Garrett.
Great, thanks. And Moses, I think we'll go ahead and start on a presentation. And then maybe at the end of the three different parts of the presentation, we'll open it up for questions and discussion. So with that, let me just see if I can share the screen. Please let me know when you can see the screen.
Yes, we can see, but you seem to be in your presentation mode.
Thank you. Excellent. Thanks so much. And so this is part of a larger series, and we're excited to really talk about the open content that's based on open standards. I think last week you heard Dr. Stephen Wanye talk about open standards, and this is really about making use of those open standards and bringing them to life in documentation and in code that can help you to build different software products. I'll just maybe note that this work is in the context of a broader global digital health strategy that WHO member states have signed on to and advocated for, which within the document, and it's not a WHO global strategy, it's 194 countries global strategy for a 5-year period. And it really acknowledges and recommends that countries like Kenya plan for a national digital health architecture, a blueprint and a roadmap, and that they make use of open standards around health data content, and also software that is that can be reused, so that there is an opportunity to make use of that, and that it can also, each software system can interoperate with with other systems that are in the ecosystem. There's a recognition that in order to ensure that systems are able to interoperate and that there's a sufficient level of quality in the data, that interoperability standards are really important for that. So the strategy promotes the use of syntactic and semantic standards, and that we acknowledge as being important to make use of for recommendations around specific content areas. And the way that we talk about that is the work that we're going to talk about today in the area of smart guidelines. As an organization, you are probably familiar with the work that we do to advise governments, and that includes the development of clinical public health and data recommendations in the form of guidance and guidelines. And WHO produces about 25 guidelines a year, and they include clinical and public health practice. And they are, in a sense, they're the starting point for countries to adapt, for example, the schedules for vaccines, or the recommended practices around how many antenatal care visits and what kind of actions and what kind of health intervention should take place within each of those visits and by whom. So these are normative documents. They're meant to be very operational, and they're meant to appeal to both the decision makers who are planning health programs, but also the clinicians and health practitioners who are implementing and ensuring that they are delivering care to patients. Just a sample of some of the different guidelines that have come out in the last 2 years. But if you can go to WHO's website and you can find a large number of guidelines that are available and are being made, that are being used across the globe. And countries like Kenya oftentimes take this content and locally adapt it with national priorities in place. When we think about digital systems, we think about, well, how can we adapt that recommended content in those clinical and public health practices and those protocols, for example, or minimum data sets? How can we bring those to life in digital systems? And so WHO will produce a guideline, and Administrative Health will look at it, and they will adapt it into the names of drugs or the according to what they may have in the system and the types of health workers that might be providing that care, and the type of insurance that may be in place to ensure that people are covered by those. And we see that technology partners to the ministry are often bringing to life those practices, those recommended protocols into digital systems. And that can be a process that can take considerable amount of time. And once those software systems have been adapted, then the health workforce and individuals are making use of those digital systems to be able to really reinforce good practice and ensure that data is collected and shared in the right formats, so that services are improved and quality of care and coverage of health interventions are maintained. We know that that is a very difficult and arduous process that can take a lot of time for governments to adapt, but more importantly for this conversation, oftentimes it can be challenging for software developers to know what minimum content should and could be brought into a digital system in the format that makes it accessible to engineers who are more comfortable with requirements documentation and specifications that they may be able to build software from. And so ministries have a challenge to know whether or not software products are consistent with what is being recommended by ministries and by WHO, and whether they contain the minimum data sets, the right clinical protocols in the right formats. And so that it becomes really a black box. It's difficult to perhaps trust in the products that are available, and it's also it takes a long time. And so we wanted to ensure that we were making available content that makes that process much easier for software developers and for ministries to adapt, localize, bring to life in digital systems, and to make use of software interoperability standards. We recognize that in order to really fast track and ensure that countries are able to do this, that we as an organization would need to bring to life our guidelines, not just as narrative sentences, as statements, but also as code, also as minimum data sets, also translated into standards and documented in a way that software engineers could more rapidly understand and bring into systems, so that we could advance interoperability standards, and that local developers would have a much more informed way of developing software. So what does this future look like? From our perspective, we're trying to ensure that there's uptake of recommended evidence-based protocols, and we feel like an approach where we're getting this content out could, in fact, not only ensure that there's faster uptake of evidence-based practices, but also that there's a possibility for more precision in the healthcare that's delivered to an individual and through a health worker, and that there would be increased ability for ministries to not have to spend as much time on developing that documentation from scratch, but could take the content and localize it and really use the limited resources that are available to focus on the adaptation process for the content, to really bring to life software that is making use of common requirements that are out there. So ensuring that ministries could use the limited resources that are available to ensure that they're able to develop with software developers in a faster way by reusing this common content in open standards, and making use of open tools that built around these specifications. Also making sure that there was consistent data representation and metadata, so that systems that countries are using are going to be able to interoperate with one another, and that countries can confidently evolve or shift from paper into digital systems and know the pathway that it will take. We also recognized sometimes there's a reliance on companies that are not in the country, and we're very supportive of local entrepreneurs being able to have the resources and have the tools and have the content to be able to build software themselves, and ideally in a way that is consistent with what would be recommended, and that over time healthcare workers then not only are using a specific software, but that these different softwares fit and interoperate with other software through open standards, and that over time health providers gain trust in the tools that are used because they know that they are consistent with evidence-based practice, and that the data is not just collected for the purposes of reporting, but also is able to populate decision support that can help them provide appropriate clinical care, but also populate the reporting requirements that may be needed at the national level. So the area that what we call this work is something called SMART guidelines. And the SMART guidelines are, it stands for standards-based, machine-readable, adaptive, requirements-based, and testable. And what it amounts to is a set of documentation code and software that is consistent with what is recommended as data, clinical, and public health practices in WHO's normative content in the guidelines documents and guidance documents that we release, in hundreds of documents every couple of years. So there's a lot of documentation out there, and we wanted to make sure that we're able to go from what formally was released as just a narrative document, where there would be a statement of a child should receive a vaccination, within a period of time and according to their weight, to actually what that looks like as requirements for software development. And so we have this 5-layer framework, knowledge layers. The narrative is the layer 1, which is really traditionally how we released and published our guidelines as documents. And they might be a 150-page document, and you may have to sift through it and figure out exactly how to interpret that for a software system. Really where we started to go into smart guidelines, and this is the innovation on WHO's side, is we recognize that software engineers like requirements documentation, and they like it in a particular format. So this layer 2, this operational format, is one that really illustrates the areas that as a software developer, you'll be able to make use of to understand how to develop a system. And that we would be able to evaluate whether a software system is consistent with these requirements. The layer 3, the machine readable content, is where we ensure that there is code that can be run across any system that is able to run FHIR. It makes use of semantic and syntactic standards. So syntactically, we use FHIR mostly. And on the semantic side, we use ICD codes, SNOMED GPF, as well as LOINC. So we try to use open standards that are where the country is not going to incur a cost for using those standards. On the layer 4, this is software that is reflective and representative of the content and clinical protocols and data elements that are at the L2, L3, and L1 level, and represent kind of how a software system should function. And we call it a reference software because it reflects exactly what we would have expected, but it isn't yet localized to a country setting. And the dynamic reflects the fact that when you have data sets that are accurately represented in a standard, you're able to begin to use machine learning and AI to be able to optimize the algorithms that might be in the software. So each of these represent a different knowledge layer, and I'm going to go into this in a little more depth to demonstrate exactly what is in the L1 through L5. And then for both, what resources are available to you, and then also what software looks like that has been developed using content in this area. So this goes into a little bit more depth of what is in each of these layers, and I'll share these slides with you so you have access to these, and they'll a set of links that make it possible for you to download the content from different areas like immunization or maternal health or family planning or HIV. There are a number of areas where we have smart guidelines developed at the L2 or L3 level. We always, as an organization, have developed L1. Now we're using the L2 and L3 to make accessible this content so that software can be then developed at the L4 level. So what are the scenarios for smart guidelines? Well, as a software development community, oftentimes we're in a situation where we've developed something, but we're not quite sure whether the software is aligned with the data that is being recommended by WHO to be collected for indicators, or we're not sure it's consistent with the clinical recommendations around screening or immunization schedules, et cetera. So this can provide you an opportunity to see what the decision logic is, what the minimum data sets are, and align your existing software with content that's available. Is looking at paper systems, and they're trying to figure out, well, how do they bring them to life in a digital way? And so this documents, the smart guidelines document the operational workflows, the expected personas of the different users, the minimum data sets, decision logic, and other the opportunity as a community to optimize. And so it also provides opportunities in this documentation to show how optimization might take place. Another scenario is a country might be advocating for software to be consistent with what WHO recommends for a particular health area. And this gives you a great place to start to look to see, well, how do you actually do that? And where a country may have even localized that L2 content or L3 content, then you have even more granularity as a starting point to be able to build systems. We know that some countries are even defining those specifications as requirements, so that countries are then, or software developers are then able to build software and know that the government will allow for it to be part of the national digital health backbone. But I think in general, this is another scenario that often comes up. And the last is standards, interoperability standards are often thought of last when software is being developed. And often that becomes the most expensive thing to be added afterwards. And so we have provided mapping to all of the relevant ICD, LOINC, as well as FHIR and SNOMED GPS standards to make it possible for you to bring to life the interoperability standards in the system so that you can connect to other systems and know that the data is represented in a way that's going to be understandable. When we think about the development of systems, we often think about the burden that health workers have and want to minimize the burden that they face when having to report. And so we really focus on the principles of collect once and use many times. So we have developed documentation in a way that if the data is collected on the phone at the point of service, then it's able to then populate the primary use case that may be important for following a patient over time, but also populates information that would be enforced. A health provider is providing care in a way that's consistent with clinical recommendations, but it also provides the data that's needed to be able to monitor performance at a district or a national or a global level. And so all of that is really, the secondary data use is also included in the documentation that you'll see in the SMART guidelines. Lastly, we recognize that increasingly people want to have data about themselves on their own phones or in their own personal health record in the cloud. And many countries are starting to go down this pathway of ensuring that an individual has a record that they're able to carry with them. And so to do that requires the tooling that a healthcare worker is using is done in a way that where standards are made use of, so that when data is synced to the individual's phone, it is able to populate something called the International Patient Summary, which is consistent with the FHIR specifications. And so this approach that we'll talk about in a little more depth enables you to see what the content is for a particular health program area, like immunization or like maternal health or like child health, so that an individual can have access to their own record as well. Lastly, one of the reasons why we developed this approach is to ensure that we were able to help countries move beyond the often current situation where each different health area let's say maternal health or HIV or immunization, has its own specific software platform, and that with proprietary data models built in, and then the logic for utilizing those that data is often baked into the system. And so to be able to interoperate between these systems, custom adapters had to be developed, and that's really expensive. And so we recognize that if we were going to help countries move beyond using single silo vertical systems for each health program area and beyond having to use a custom adapter, that they would need to be able to make use of open standards that not only represented the way that data is represented in the device or in the system, but also the way the logic is represented. And so we're often using FHIR for the way that data is represented, and we're using standards like clinical quality language, CQL, as a standard for how the logic is represented, so that then there is consistency across the ecosystem of tools, and they're able to exchange data. And there's a lot of advantages because common tooling can be developed around the recognition that these standards can be expected from each system, and the tooling in an ecosystem can evolve quite quickly. That makes it possible then for software developers to make use of tooling and not have to reinvent and build a lot of tooling themselves. I know you'll hear more about the Open Health Stack and the tooling that was developed by Google to make it possible for software developers to quickly develop applications. And that's because this tooling is recognizing that FHIR and CQL and other standards are at the heart of that. So it makes it possible to do it much more quickly. I'll quickly just go into what does it look like? Smart guidelines, I understand it hypothetically, but I actually want to see what it looks like. So this is layer 1 of the knowledge framework of smart guidelines. And this is from the antenatal care pregnancy area. There are 49 recommendations, and they represent an ecosystem of resources that you would have to read if you were trying to translate your content from WHO or from the government in Kenya or elsewhere. And you'd have to interpret narrative recommendations like this, where oral iron and folic acid supplementation needs to be provided to an individual who be provided in a frequency of so many times per day or so many times per month, etc. And this becomes important for how you interpret a software and how you develop a software system. So we'll look at that same content in L2, which is the Smart Guidelines Layer 2. And within each of the Smart Guidelines Layer 2, or we call these digital adaptation kits, there are 8 areas. The specific health interventions, who are the users of a software system, what are the common scenarios of use, what are the expected business processes and workflows that you'll see, what are the core data elements that should be represented in any software, facilitate and augment and reinforce good clinical practice, what are the indicators that may need to be calculated from the minimum data sets, and then what are the functional and non-functional requirements for building a software system. And so to look at each of these, when we were looking at the user personas for this, for the antenatal care smart guideline work, we recognized that there were 3 different personas that needed to be represented in the content of the smart guidelines, and that there were specific scenarios in which they would be expected commonly to use these systems. And so this is all documented in a way that you as developers can look at it and understand how to make use of this in Kenya. There's a menu of different operational and business processes that gives you an opportunity to look at the different interactions that the different personas have, whether it's at the starting point for registration or whether it's on the reporting side for indicators. And an operational workflow looks like this, where you'll see the actual engagement with the client to the provider, and you'll see specific actions, decisions that have to be made, and then how those translate into functional requirements on the devices or on the software systems. We also include the minimum data sets and how they're represented, and we describe exactly what each of them are, and then we link them to the representative or the necessary standards or concepts like ICD SNOMED, LOINC, or HL7 FHIR, so that it makes it easy for you to adopt interoperability standards. We also knew that in this case, there was decision logic that came from a variety of different sources, and we codify that in a way that you're able to look through and understand where the source of the documentation comes from. And that then is translated into specific decision model notation, which is really pseudocode. So you're able to understand whether or not your business logic is accurate and consistent with what would be recommended. And in this case, it also provides cutoff points so that you're able to know that and be confident that it's consistent with the most up-to-date recommendations that WHO may have released in a particular area. We also include indicators. Those indicators are ones that are often critical for the health worker or the facility or at the national level, or even at the global level, where indicators are oftentimes needing to be calculated for donors or for ministries to be able to track things. We also provide the functional and non-functional requirements, and you'll see that they're in a specific format that you would expect as an engineer to know exactly what a software system should function. The L3, this is again the machine readable content, is written in code. And again, this is exactly the same kind of content that you'll see in the L2 and the L1, but it is able to execute on a device. And this is just one aspect of it. This happens to be for the anemia, but it is, all of this code is available and is free, and it's a good starting point for building software systems. And you'll see here is a reference software, again, using that same content of anemia, and it is running the code, and it represents exactly what you would expect. So I will I will hand over to Ritika to provide a little bit more depth in this area. Ritika, over to you.
Thank you, Garrett. So now that we've seen all the layers, let's take a deeper
Would you like me to
look.
share for you?
Yes,
Okay.
thank you. A little bit of technical overview on what the L3 layer looks like, which most likely is represented as a FHIR implementation guide. So what we have here is a screen grab of what a FHIR implementation guide would look like. As you can see, it looks like a page that you can browse and navigate. So effectively, L3 content has a human readable content or human readable aspect to it as well, so that as developers or health informaticians or even people from the ministry are going in, they are able to read what is contained in the FHIR implementation guide. And there are aspects in this implementation guide where you can download the code in JSON or in XML or in TTL. So all the artifacts from the L2 that are converted to machine readable code are also present in this IG, but there is also a narrative or a human readable content to this FHIR implementation guide that is available. The screenshot that you see here is from a WHO Smart Guideline IG template. That means that we also host a basic IG template that serves as a starter kit, where if across diseases, across areas, you're starting an implementation guide, then you can clone off from this template and start making customizations across disease areas. Next slide, please. Okay, so this slide lays out the mapping of outputs for each knowledge layer across all the different components. So if the L1 guideline had some narrative questions or guideline recommendations or glossaries or indicators that were defined, then in the L2, the narrative questions would have become some form of use cases, user personas, paper forms, which in the L3, there's a FHIR artifact called questionnaire. We convert those to questionnaires. And then when we have an app, the L4 app can use those as forms or data entry templates on the UI just by loading the FHIR questionnaire. Similarly, on the guideline renditions, the L2 content has workflows, decision trees, decision tables, which in the L3 becomes the CQL library, which is the clinical quality language. And then in FHIR, there are artifacts that define the patient's care pathway, which is represented as a plan definition or an activity definition, which in the L4, by the use of APIs, can provide decision services or app services. Similarly, on the glossaries or indicator definitions, we map to standard terminologies like ICD or SNED, and we also define the indicators, which in the L3 map to code systems, value sets, measure resources, which any L4 software can use the terminology services. Everything that you see in bold is provided by or hosted by WHO. Everything else that's not in bold is an adaptation that a country must make while they are adopting these knowledge layers. Next slide, please. So this is a visual representation of the previous slide. So all the left side components are the DAC components, health interventions, personas, scenarios, processes. And on the FHIR and the CQL side, what they would map to. So if you would look at the data elements, specifically the ones in purple, on the FHIR side, they map to the code system, value set, concept map, profiles, and questionnaires. And they also create some artifacts in the CQL, which are concepts and data elements, so on and so forth. Okay, next slide. Thank you. So this, a lot of work goes into the L3 and the FHIR layer, right? But we are not anticipating that all of this code be done by hand. We are also working on a lot of ecosystem of tools that will help us in generating these code set. Of course, there will be adaptations that are needed, but there are these tools that we are working on that will also allow us to automate parts of this. So if you look at the left hand side, the number one is a smart guidelines exchange platform that we are working on, wherein you can, it will help you make easy the process of creating a DAC from a living guideline. So it will allow for spaces to business processes to be written, workflows to be drawn, data dictionaries to be done in a structured format. And that structured format will help us automatically generate some parts of code, which right now to generate L3, we leverage GitHub. So GitHub has some FHIR IG publisher, which automatically generates some L3 assets. So that is being plugged in. And then on the L4 side, you will see that we already have a FHIR Android SDK by Google, which helps in leveraging these resources from FHIR and then bringing them on an Android UI environment. So we are working on these tools in the ecosystem that will help also ease some of the process in generating L3 or FHIR content. Next slide, please. So from Google, there are also other tools that are in the market. So we have Open Health Stack from Google, which, like we mentioned in the previous slide, the Android FHIR SDK is being developed as part of the Open Health Stack initiative. So there are more tools out there in the market that even Google is building on that can help code generation in FHIR. Next slide, please. Okay, so some more information about smart guidelines or what's happening in the community. So as of now, this table shows the current status of smart guidelines in development. So you can see the antenatal care, we have the L2, the L3, and not in FHIR native, but some executable code that's available. We also have child health and emergency settings that you will soon see a demo of right after I pass it over to Chris. But across different health domains, what is our progress on creating these smart guidelines across L2, L3, and L4? Next slide, please. So we also have a website, a GitHub repository for World Health Organization, and where you can see all the L3 content that has been published so far. And for any further information, you can always email at smart@who.int. Next slide. So we're also trying to build a community around the FHIR standard for smart guidelines and global digital health initiative. So we met in April. This is a picture from our meeting in Geneva in April, where we met and spoke of this community that we are trying to build and onboard more people and grow to, so that we can have a shared learnings, shared progresses, to work together on creation of tooling, so that generating code for FHIR is simpler, adoption is easier, to also define best practices for curation of the L2, L3, and L4 layers of smart guidelines, and also to work around capacity building or training needs so that it's easier for countries to adopt the smart guidelines. Next slide. So right now, these are some, these initiatives are already active in our community, and people are welcome to join in on these communities. So we have an authoring call that speaks about how the L3 content should be authored, how FHIR implementation guides should be authored. That's held every Monday. A call for all L4 developers who are developing applications that are using L3 content on Tuesdays, and a developers call every Thursday. Also, please check out the chat.phir.org on Zulip, where we are actively discussing any problems, any blockers that we have in developing this, in developing smart guidelines or FHIR IGs. And yeah, these are all the ways you can reach us at, and I will pass it on to Chris for a demo. Thank you.
Thanks, Ritika. I'm looking at the time. I'm wary, Moses, that we are slightly over time already. Are we okay to continue with this last section, or would you like to take a pause for some Q&A?
Just continue. I ask the participants to post their questions in the chat.
Fine.
In the Q&A section.
I'll be quick. Okay. Yeah, so very briefly, we have a project now called MCARE, which is all about using the smart guideline approach, which Garrett's described before, and applying it in emergency settings, where adherence to guidelines and providing high quality care there can be particular challenges that are posed in those settings. Our starting point for this project has been a guideline, an L1 called IMCI, which stands for the Integrated Management of Childhood Illness, because this is where through the narrative guideline with prompts on what questions they should ask, on certain observations, signs and symptoms they should look for. And then when they move to the right, they will reach a classification based on that guidance, which will be either in the red or the yellow or the green, depending on the severity of the classification they reached. So that's how it's presented right now. And this is, if you like, the job aid that many health workers use currently. But it is actually a lot of information to digest, and adherence to this can vary in different settings. So when we apply the smart guideline approach, the next step, if you move to the next slide, Garrett, was to develop the L2, which was the digital adaptation kit. And I've just illustrated here some of the components, not all of them, from the DAC for MCARE. So one of them is just to describe the high-level business process. So for us, it's the patient encounter, the consultation, from, again, left to right, from the start to finish, from the point they enter and they're registered, then they move on and they're assessed and they reach a classification, then there's a treatment, and then there may be further follow-up or referral, and then they leave. So we start by mapping out the consultation in these stages. And the next slide. And the next slide is then to list in a data dictionary, another component of the DAC, every data element that needs to be collected to fulfill the recommendations of the L1. So you can, I don't know if this is showing up very well, but you can see here then the prompt for ask for cough is that first row. And then there's all the information about what data type it is, or the validation rules, any conditional logic that should be applied. And like Garrett said, when this comes down to classifications, this would be mapped to other relevant standards like ICD or LOINC or SNOMED. Okay, you can move on, Garrett. Oh, I think you skipped one there. You go back one. So when we have listed all the data elements, we can also start to present them in the form of decision logic. So again, we can start to put them together if cough is true on that top row, or if difficulty breathing is present, and there is any of those other conditions in the next row, and there may be other ands. You can see that the logic and that works from left to right, and then we end up with an output or a classification in the colored cells there. And again, so it shows you how do we reach those classifications in the red or the yellow or the green. So it's kind of a more readable way of presenting that information. And then the final column is the action. So what should, based on that classification, what should the healthcare worker do? So we can write it in a table format. The next slide shows the same decision logic, actually just visualized. So we can also just write it in this more of an algorithm, kind of a flowchart way, which again is the same information, but it can be easier when we're presenting this back to the ministries of health, to the program managers, to show that this is your narrative guideline, just reflected more in a human readable, on its way to being a fully digital form of guidelines. And then the next one, Garrett. And the next step is to take those L2 components and write them as code. So this is the L3. And again, this is a snapshot actually of the output of the L3, but it means that we take all of that data that's collected on a mobile phone. It's then sent to a FHIR server and mapped to FHIR resources. So that's where we map it to the standard of FHIR, where there is decision logic, like if these conditions are present and others, we can write those using the clinical quality language that Garrett mentioned. But it means then that the final output is of this consultation is a record mapped to FHIR, which is then in this interoperable standard, and it can be reused and exchanged with other systems. There's a question I saw about where are these L3 published? So we put the link there. All of the final L3s are published to the WHO GitHub site. And the final step then is also the L4, which is the actual application, which ingests and executes that clinical content. So we have a reference app we developed for MCare, and I can do a very quick demo if there's time. And if the technology, if you stop sharing, Garrett, yeah. And just gonna let me. Okay. So hopefully there might be a bit of a lag. So I'm showing you now on my screen, this is the app and how the app looks. So I won't go into the details, but I can add a patient. I'll open this first patient, which has I've opened this patient, which I've just given an ID of 133446, start a consultation. And now I'm being prompted, is the mother accompanying this child? I'm going to put yes, I can submit. So now I'm progressing through the IMCI guidance. And again, in many ways, this may look familiar to some of you because this is, in some ways, is not new. There are already apps that do clinical decision support, even for IMCI, this guideline. The difference is that this is not hard-coded. The logic, the questions I'm being prompted, and then when I move to the next screen, the things I'm being asked for here are based on my previous questions. This is all being done natively on the phone using FHIR and using this FHIR IG. And you can see I'm being prompted for temperatures, And based on in the data dictionary on the ranges, it's determining if it's normal or not. Let me give this child a weight. And I progress now through the entire consultation. It's referencing the IMCI guideline. Here's that prompt. So I will say I've got a cough. I'll say I've also got difficulty breathing, nothing else. And we'll see if I can reach the right classification based on the things I've inputted. A bit of a lag. So then I'm being prompted now for relevant signs based on the information that this child's presented with. I've given it fast respiratory rate, no chest and drawing, but I'll give it stridor. Stridor for us is an important sign. I'll give it nothing else. We'll determine based on my information, are there any additional tests that need to do or assessments? In this case, there's not. And so now it reaches classification. There's a bit of a lag with my screen sharing. Right, so now it reaches this severe pneumonia, which was the red classification that we saw in the initial guidance, so it followed it correctly. And it actually, what IMCI also does, it tells you what things were not present. So there was no throat problem and no anemia, but they are still, the mothers still need to be counselled. So I'll confirm what we've done, because this is decision support, we allow the healthcare worker to actually agree or disagree with this classification. So if in their clinical judgment they think that actually there was a throat problem, they can reject that, but I'll agree with everything the app's told me, and it then gives me the relevant treatment for each of the final classifications that I reached, and then I can submit that. And that will be part of the child's history then. If the child comes back for another visit, there can also be the longitudinal follow-up, which is allowed, because that's what FHIR also enables us, so we can track more as a longitudinal follow-up for the child on how their weight and their temperature measurements and so on are evolving over time. Great. So with that, I'll stop, Moses, and maybe hand back to you in case there's still some time to go through the questions.
Yes, thank you very much, Chris, Garrett, and Ritika, for your very valuable contributions. Now, there's some questions in the Q&A. Some have already been responded to, but you're welcome to expound a little bit on them. Garrett, Chris, and Ritika, there is 2 unanswered questions there. And as you look at that, I have a question of mine. One, I think some of them have been answered. I wanted to know whether the reference software is available. The code, I think you said, is available on GitHub. Then the core data elements, I asked if they're available beyond ANC, but I've seen there's a lot of work in progress. Finally, how are the updates in L1 synchronized all the way to L4? Because I noticed there's a lot of layers down there. How and how fast does that happen? Say I pick up some of the core data elements and run with an application, and there's an update in L1. How fast does it trickle down? At least for me to access it and apply, as you also address the other questions in the Q&A. Thanks.
So maybe I'll take a first stab at that. Thank you so much for the questions. They're excellent questions. So we'll make available all of the links to the documentation. I think in the slides, we'll make available the slides to everyone on the call. But maybe just to note, there is, we can, all of the L2 content is available through our website, and then all of the L3 is available through GitHub on the WHO repository. And we can also provide a link to all of that. What we are aiming to do is to ensure that as recommendations change, which tends to happen currently every couple of years, unless it's something like an emergency is taking place, and for example, COVID, the recommendations changed very quickly. But our intention is to change the content in the L3, which is the GitHub repository, as soon as we can. So that will be made available very quickly, whereas the L2 takes a bit more time, even though it's just narrative documentation, but it often takes a little bit more time because there are clearance processes that have to take place. Whereas on the L3, because it's in a GitHub repository, we'll make it available very quickly as the changes are, as they are made through WHO. Where there's a new recommendation, we will make changes on that. That can then be looked at by the government as well as to incorporate that recommendation. So really, it's the sovereignty of the country and of course the software developers to look through and think through how they might incorporate that. Maybe I don't know if there were any other questions, Chris and Ritika, if I missed anything.
Maybe just to complement what you said as well, Garrett, but I would say in terms of the speed by which you can then implement updates and get that then used at the point of care, Moses. I mean, like Garrett said, I mean, it takes time depending on the cadence of the actual evidence base changing, the recommendations coming through. But once it's then authored in the L3, of course, you then have a direct pipeline to the L4s. So we're piloting now MCare for the first time in Iraq. So we have a network of 35 doctors that are using the application. And if we did actually need to update the L3 after it was launched with some small change, instead of unique identifier, they wanted to call it family number, these sorts of small changes. But then we can just push an update to the L3, they synchronize on their phones and they receive the new content. So the beauty is that still you need to, of course, like Garrett was saying, go through the safeguards and make sure the ministry would like to accept the new recommendations that are coming through. But it does mean they have a very much more direct pipeline to then getting that, when those changes are implemented, getting those down to users at the point of care, which has been a big challenge up to now. I can maybe there's a question as well about one on sort of data protection, and if from Tony asking about how secure is the patient's info in a system where you're potentially exchanging data between different healthcare departments. And I think I'd say, Tony, it's not, this approach and smart guidelines, it's not bringing with it its own sort of data protection principles or policies. It would simply adhere to whatever is already in place at national level. And I think generally speaking, you could say, starting point, especially with patient level data, is the starting point is that should not normally be shared outside even of the health facility. There's not normally a reason why at national level you need identifiable patient information. It should be anonymized, more for aggregated use and reporting on indicators and so on. There can be exceptions, of course, but again, that should be defined in a national policy, and we would just be helping to promote that and enforce it through the use of the L3s and the L4s. I think that would be my answer to that one.
Yeah, there's plenty of questions in the chat.
I was just going to say, it's not just for governments. No, it's for private sector, as well as implementing partners, anyone who would like to make use of the code or the content. Our hope, and again, there's no fee. Our intention is really just to get good content out there and the tooling that can make it easier for governments and private sector to build good code, good apps.
Okay. So any more questions there in the chat? There's 2 that are open. I guess
I think the application, obviously the governments usually have recommendations on who provide services to patients and for what purpose. So obviously the software is really to augment what policies are already in place. So we're not advocating for someone to use the application to themselves become a health provider if they're not already credentialed to be one. but I think it's maybe priority areas for us. Thanks. Which will be our main role in all of this. Maybe if someone could clarify with a second question. I'm not sure I understand that question. By Faki Mohammed.
All right, there's another question there.
While Faki is adding maybe to that, I'll just say this is part of a broader seminar series, and so my understanding is the first session was really around the relevance and value of open standards. This session was really about the relevance and role of open content that makes use of open standards, and subsequent sessions will provide software tooling and guidance on how you can combine the open standards, the open content with open software to be able to develop software applications. And so if you're a government employee, then these are resources you can make use of.